Welcome to the conference session titled Managing Side Effects of Bone Marrow Failure Diseases. Thank you for joining us. My name is Julie Powers, and I'm the Senior Director of Patient Advocacy at AAMDSIF. I will be moderating the presentation today. As we get started, we recognize the generosity of our corporate sponsors and our patients, families, and caregivers who have provided financial support for today's conference. In the beginning of the session, we will open the audience poll feature in the right-hand engagement panel. Please click on the icon in the panel to navigate between each as you watch the session. The poll will remain open for the first 5 minutes of the session. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon on the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your healthcare. During the session, we will open and close polling questions from the audience, as I noted before. Please be sure to click on the icon to navigate between each as you watch the session. As a reminder, today's session is being recorded, so if you want to watch it later, it'll be available about an hour after we finish this session. Today's specialist is Eric Padron. Dr. Padron is an associate member in the Malignant Hematology Program at Moffitt Cancer Center in Tampa, Florida. His clinical interests are the care and treatment of patients with adult myeloid malignancies, including MDS, AML, and myeloproliferative neoplasms. With that said, welcome, Dr. Padron.
Thank you, Julie. Thank you for the introduction, and thank you for the invitation. These types of conferences are one of my favorite things to do because I really like to spend time talking to patients and families who are afflicted with these diseases. And, hopefully the slide deck is informative, but I hope even more that you guys have lots of questions that we can address and start a conversation. So with that, let me share my screen so you can see my slides. Okay, great. So the title of my presentation is Managing Side Effects of Bone Marrow Failure Disease. And these are my conflicts of interest and disclosures. And this is today's agenda. I thought, let's start talking about what we mean by bone marrow failure diseases, which is a bit of a generic term, but let's talk about what they have in common. Let's discuss the side effects or the symptoms related to the diseases themselves. And then let's discuss the side effects related to specific treatments of these diseases. So what are bone marrow failure diseases? Well, let's talk a little bit about what the bone marrow is. I always tell my patients that the bone marrow is that squishy stuff between or inside our bones. And it's really a factory where we make all of our blood cells. It's a factory that's always working. It makes about 2 trillion blood cells a second, but it does it in a very coordinated way. This is a diagram on the left of or a cartoon diagram of what it would look like under the microscope. I'll actually show you real pictures in just a second. And on the right, you see that there is this hierarchy of cells. And so it starts with the hematopoietic stem cell, which can turn into any of the downstream cells. And this is one of the critical cells in describing what the bone marrow failure diseases are and how they manifest. So we went from a cartoon to what a normal bone marrow looks like. So this is what a normal bone marrow looks like under the microscope. You see a bunch of different cells of different sizes and shapes, different colors. And you see, importantly, these white globules, and these are fat cells. So our bone marrow is made up of fat and cells. And it turns out that the amount of fat that you have and the amount of cells changes as we age. And typically we say 100 minus your age is the amount of cells or the percent of cells that we would like to see. So if you're 70, we would like to see 30% of these be cells and 70% be fat. When those ratios are different, then that's where we start seeing abnormalities that are characteristic of bone marrow failure diseases. So this is one disease. This is an aplastic bone marrow that can be from acquired aplastic anemia, where you see almost everything is fat. And we would say that this is less than 5% cellularity, and is really the pathologic hallmark of aplastic anemia. But maybe, as you may not expect, bone marrow failure diseases can also have too many cells in the bone marrow. We call this hypercellularity, and it's characteristic of MDS, for example. And these cells are accumulating because, number one, they're making more than they should. But number two, and more importantly, is that they can't mature into the normal blood that you need. And so they kind of get stuck in the bone marrow. So bone marrow failure diseases is a general term, which is sort of summarized by this figure. So you have bone marrow failure diseases in general, but you also have within that immune mediated, the most common type of bone marrow failure disease. And that could be from a variety of things, but the most common, or at least the most relevant to this program and foundation, is aplastic anemia, but there's a host of things that are immune mediated. Then there's MDS, which I just talked a little bit about. And then, of course, drugs, radiation, and then there's really rare inherited bone marrow failure diseases, which I won't talk too much about. And then there's some diseases that can have bone marrow failure sometimes, and sometimes doesn't, like PNH and acute myeloid leukemia. But what we would say about all of these bone marrow failure diseases is that they have in common the fact that blood production is low. We call this ineffective hematopoiesis. There's a lot of routes that the different diseases get to this ultimate outcome, but what ties them all together is the fact that there's ineffective or low blood production. And almost always the manifestations of the symptoms that people get with these diseases is tied to that low blood production. And so we'll go through the various side effects of having various portions of our blood low. So the first one is anemia, which is a term that means low red blood cells. We know the red blood cells are the cells that carry oxygen to our tissues. And so it may not be surprising that people with anemia may just feel slightly fatigued, tired, could experience heart palpitations, shortness of breath. They can look pale. And as the severity of the anemia worsens, as the number goes lower on your hemoglobin or hematocrit, the intensity of the symptoms could worsen. And if you get a blood transfusion, for example, those get better. That gets me to how we mitigate anemia symptoms. Well, number one is effective therapy. The goal of most therapies for bone marrow failure diseases is to get the blood counts better. And if we find that treatment for you and they get better, well, that's the ultimate goal. There's also these things called erythropoietin stimulating agents, or EPO therapy. There's a lot of them. They're called Procrit, Retacrit, Aranesp, etc. But the general principle is this, when under normal conditions, so no aplastic anemia, no MDS, when patients are anemic, there is a protein secreted from the kidney, believe it or not, that goes to the bone marrow called erythropoietin. And that protein actually stimulates the bone marrow to make more red blood cells to correct the anemia. And so in some cases of MDS, for example, when the erythropoietin levels inside the body aren't very high, we can actually give recombinant or synthetic versions of erythropoietin via injection, and that can help stimulate, in some people, their red blood cell counts. Of course, red blood cell transfusions are another way of doing this, but it's important to know that 1 unit of blood contains 200 milligrams of elemental iron, and our body has no way of removing iron for which we're exposed to IV. There's a system of excluding iron in the GI tract, but if you get iron IV, it's going to stay there unless you remove it with medications. So after 15 to 20 units of blood transfusions, you can develop iron overload, and that can have its own consequences. For example, it can deposit in your liver, your kidney, your heart, and cause damage. The other class of low blood production is the white blood cell, and we'll focus on the neutrophil. You can see a diagram of what the neutrophil is important for on the right, but you can it can be summarized as sort of the infantry soldier for your immune system. So it's the first line of defense. And in many patients with bone marrow failure diseases, these soldiers are reduced. And so you may be more susceptible to infections of all kinds: skin, sinus, lung, urinary tract, fever may accompany these infections. And it's important to note that when you have fever and low neutrophil counts, we call this neutropenic fever, it's a potentially life-threatening problem. And so you have to get to the emergency room. Good news is if you get there quickly enough and you get antibiotics, most people survive and come out of it just fine. But it is something that people with bone marrow failure syndromes have to really monitor closely. Many of my patients, we talk about taking your temperature 2-3 times a day, even if you feel okay. Again, this will be a common theme. How do you mitigate this? Well, effective therapy could do it. Similar to the erythropoietin system, there's also another protein that can stimulate, not secreted by the kidney, but secreted by a variety of cells that can stimulate the white blood cells and the neutrophils to grow. Now, there's been so many studies. This is used not only for bone marrow failure diseases, but used actually more commonly for cancer patients undergoing chemotherapy to get their neutrophil counts up. But what we know is that at the end of the day, what the data shows and what this drug does is it gets your giving growth factor if you're really sick and have any issues with infection in the hospital, and that can certainly help. Can you guys hear me okay? I just got a link that my internet connection was unstable.
We had a little bit of a hiccup, Dr. Padron, but I think we're good.
Okay.
Thank you.
And so another thing that you may hear from your doctors is something called prophylactic antibiotics. And that means that you start antibiotics before you have an infection to prevent infections. While it may intuitively sound like a smart thing to do, data as to whether this approach actually prevents important infections is unclear. And it really depends on the treatment you're receiving, and it depends how long you've been neutropenic. And it also depends on whether you've had neutropenic fever events or sinus infections in the past. And so my general practice is, especially for example, let's say in lower risk MDS, if someone is neutropenic and they haven't had any infections and they're tolerating their therapy fine, I don't necessarily start these medications because they can have some side effects and they can interact in some cases with the medications that that we give you for treatment. But if you've had these infections in the past and you've had prolonged neutropenia, it is something we consider. So and I apologize, there's the text here is incorrect, but I'll just describe what thrombocytopenia is. Thrombocytopenia is a low platelet count, and the platelet system is the blood component that actually helps your body clot. And as you may expect, then patients who have thrombocytopenia or low platelets can get easy bruising, can get nosebleeds, gum bleeding. In rare cases, can even have bleeding in the brain denoted by this CT scan. This is called a subdural hematoma, which can be very dangerous. And the important thing to note, though, is that really your body has a fairly good redundancy of platelets. So the lower limit of normal is generally around 150. But you can have a surgery when your platelets are over 100. You're very unlikely to bruise or bleed if your platelets are over 50. But once you get below 50, there's certain precautions, like you shouldn't take aspirin or NSAIDs. And then once it gets below 10, you really should get a platelet transfusion, because the chance, it's not a guarantee by any stretch, but the chance of you having bleeding in important areas like your brain goes up. And so it's important to get platelet transfusions then. Again, effective therapy can mitigate that. And again, you see the theme, there are actually proteins that are made that stimulate your platelets. This protein is called thrombopoietin, or TPO for short. And there are drugs that either chemically mimic TPO or actually are recombinant or synthetic versions of TPO. And these could be administered and are often administered in diseases like aplastic anemia with a high degree of efficacy to restore not only the platelet count, but in fact, TPO receptors are actually present, as you can see in this diagram, across all the blood cells, including the hematopoietic stem cells. So actually, in some cases, it helps other blood production as well. And then I talked a little bit about the pros of a platelet transfusion, but the cons could be is that it's cumbersome and you don't always want to be getting platelet transfusions every other day. And the problem is after a long time of getting platelet transfusions, you can become resistant to it. Now, it's more of your immune system fighting the platelets, and that can happen primarily, the first time you get it, or secondarily after multiple transfusions. But it's something that makes this process more challenging because we in an ideal world like to keep your platelets above 10, but sometimes can't do it because of this. All right, let's talk about side effects of therapy. So again, we're going to focus on the two common ones. So aplastic anemia, just as a reminder, is just that decrease in cellularity or blood cells compared to fat. That's what we see under the microscope. We know that's because of a depletion of those stem cells. The stem cell pool is decreased, and it can be decreased for a variety of reasons, but the most common is that it's an autoimmune event. In other words, your other cells in your immune system are actually attacking your stem cells, and that explains why your doctor probably recommends immunosuppressive therapy. But there are other reasons too, some inherited, in where there's defects in how the stem cells replicate and maintain themselves. But ultimately, the common theme is that there is a depletion of the stem cell pool. Myelodysplastic syndromes are a little different. There's actually too many of them present in the bone marrow. We know that depending on the type of myelodysplastic syndrome you have, there is a what we call differentiation arrest. In other words, there's hematopoietic stem cells there, but they're malignant, they're cancerous, and they can't make the blood that your body would like it to make. Now, the average age of diagnosis of this disease is about your 70s. Aplastic anemia has what we call a bimodal distribution. In other words, there's a group of adolescents and young adults, and then there's a group of people in their 60s that can get this disease. So let's talk about some of the treatments. One of them is called lenalidomide or Revlimid, and it's FDA approved for MDS. It's orally administered. It's given either daily or 21 days in a row with a 7-day break. It's highly effective in patients who have a specific genetic abnormality in their blood cells, which is a deletion of the long arm of the 5th chromosome. And side effects from this therapy could include lower blood counts initially, prior to response. It turns out that some studies say that this is actually a sign that you're gonna respond. And so, although it requires the reduction in dose, it could be a sign that your disease is sensitive to Revlimid, and so that could be a good thing. GI symptoms like diarrhea and nausea can happen. Those can be mitigated most of the time with medications. Excuse me. Skin rash could also happen. It can be quite common. In most people, it's not a deal breaker, and there are actually some topical therapies that can be given to improve it. But in some people, it can be significant enough to where it stops. It prevents your doctor from giving it to you. And then rarely there are cases, because Revlimid can actually stimulate some aspects of your immune system. It can cause autoimmune-like side effects in some people. And then Revlimid or lenalidomide is actually a cousin of a drug called thalidomide, which has been unfortunately notorious and historically associated with birth defects. And so there is a great length that both the company that makes this and your doctor go through to ensure that you are not pregnant and will not get pregnant while on therapy. The next class of symptoms are called hypomethylating agents. So hypomethylating agents are FDA approved for MDS and AML. These agents include azacitidine or Vidasa and decitabine or Dacogen. Both can be given subcutaneously and IV. There more recently has been FDA approval. They have different names, but FDA approval for orally administered versions of these medications. Depending on the therapy, can be given as a 5 or 7 day cycle out of 28 days. And the main side effects here include, again, lower blood counts, especially if combined with other medications. HMAs oftentimes are what we call a backbone therapy. In other words, because we know they work, doctors then could try to combine it with other things. And so when you combine it with other things, especially this drug called venetoclax, blood counts can be especially impacted. Constipation is common. I always tell my patients to take a stool softener on the days of their therapy, even if they're not constipated. And then fatigue can happen, especially in that second and third week, which could be something that affects patients. Sometimes, especially if it's working, we can spread out the cycles to rather than every 28 days, maybe every 5 or even every 6 weeks. But you have to talk to your doctor because the risk, of course, is that it stops working. And then probably the most common treatment given for aplastic anemia and given for some forms of MDS is immunosuppressive therapy. And it goes back to why we think that those stem cells are depleted. We think that there are T cells that are attacking them. And so this immunosuppressive therapy is a combination of 2 drugs that attack the T cells: an antibody, which is raised in either horse or rabbit, that directly attacks human T cells, and a pill called cyclosporin, which sort of chemically attacks T cells, but does have some side effects. So the ATG component is generally started in the hospital. And it started in the hospital because of this potential side effect called serum sickness, which can really lead to vacillations in blood pressure, really high fevers. And it could be described as a severe acute immune reaction because you're receiving a protein from a horse or a rabbit. This is very treatable with steroids and subsides in most patients, but it's why you should get ATG therapy in a hospital that does it a lot, because sometimes if you don't have the protocols in place, if the nursing staff or the pharmacists are not familiar with these side effects, it may prevent you from getting the full effective therapy, because they may say, well, this is something that we should stop, when in fact, if you treat with steroids and continue, it may actually be okay. And so again, while not a side effect, what we call an on-target effect, immunosuppressive therapy profoundly reduces your T cells. And of course, these are important to fight infections, so you would be more susceptible to infections while on this therapy. Cyclosporin and a short course of prednisone is usually given in the hospital, but then can continue for up to 6 months. Cyclosporin levels generally should be drawn to personalize your specific dose. And it's very important to note that you should not take your pill. So if you're going to see your doctor at 10 a.m., don't take your pill in the morning on the day of your blood test. And because doses are personalized based on the trough or the lowest level in your blood and not at the peak, the highest level in your blood. If your levels are high, you could be especially prone to high blood pressure, hair growth in the face and chin, especially in women, tremor, and kidney damage. And so it's important to keep these levels at a safe but effective dose. Next is a drug that was recently approved called luspatercept or Reblozyl. It was recently approved for myelodysplastic syndrome for the treatment of symptomatic anemia. It's given every 3 weeks as an injection. It's important to note that your doctor will increase the dose every time, up to 4 times, until symptoms or side effects occur. And some of these side effects could include fatigue. I always tell my patients and oncologists in the community to expect this, but that generally, even if you increase the dose, it resolves after the first cycle. Hypertension, headache, dizziness, nausea, diarrhea, and again, birth defects are something that is a worry. And so making sure you're not pregnant and don't have, and will not get pregnant is important. And then lastly, stem cell transplant, which we view as the only potentially curative treatment, has a whole host of side effects, and we'll just talk about it in brief, although we could do an entire series of talks on stem cell transplants. But just so you know kind of what it means, stem cell transplants are in these types of diseases from somebody else. So what happens is, here in the panel on the left, you see a donor. And so what that donor is done is they're given special medications. These special medications coax the stem cells out of the bone marrow and then allow the clinic to capture them in their blood. And so they capture basically a blood donation after these special medications, and then they process the cells to get these stem cells. These stem cells are then given to the patient, but before they're given to the patient, they get chemotherapy for a few days to clear the bone marrow that they have, and then they infuse it and they receive the stem cells. It takes about 30 days or so for the cells to take, and of course, for a long period of time, you can be susceptible to infections. The most common side effect of stem cell transplants is something called graft versus host disease. So because these stem cells are from someone else, no matter how well they're matched to you, and there are many attempts to do that, there is going to be some effect to where your brand new immune system that's healthy now sees the rest of your body as a potential invader. And that ultimately leads to what are autoimmune-like symptoms. And this is a whole list of things that can happen when you undergo transplant. This is probably the most common and most important to focus on, because while there are many medications that are given to minimize this and prevent this, this can be a fatal side effect from stem cell transplant. On the positive side, though, the same reason that you get graft versus host disease is the same reason you get graft versus disease effect, or what we call graft versus leukemia, or GVL, which is that the reason that the transplants can work long term and cure you is because this new immune system can surveil your entire body, and anytime one of these new cancer cells decides to pop up, it could kill it. And so one of the main areas of bone marrow transplant research is to help combat graft versus host disease while leaving graft versus leukemia or graft versus disease present and unaffected. So with that, I'd like to thank you for your attention. And if you have any questions, we have plenty of time to discuss. I'll stop sharing now.
Thank you so much, Dr. Padron. We do have a number of questions that have been submitted by the audience, and so I will go through them. Our first question comes from a patient who has MDS and is wondering about travel. They're concerned, and I think this is related, as we discussed before the presentation, to the COVID pandemic. Could you address that, perhaps?
Sure. So, the number one answer is vaccination. More and more studies are emerging that suggest that there could be some protection that patients with bone marrow failure diseases get from a vaccine. Because of course the worry is that, well, I have a suppressed immune system, will they even work? And it's an important consideration, although we think that it could work at least partially. But maybe even more importantly, is ensuring that your circle, your family, is vaccinated, or where you're going to be, say at a family member's house when you travel, is a vaccinated household. I think that's critical, because I believe if you have that level of protection, then I think travel could be reasonable. I always tell people that, living in a pandemic, we're now understanding that there is no such thing as non-zero risk. And so it certainly increases risk to travel, but you have to balance the risk of COVID and the obvious potential benefits of visiting family, for example. If you are not vaccinated, we estimate that about a third of people with bone marrow failure diseases are going to die from COVID. And so it is a very serious thing and something that we want to prevent. But if we're vaccinated, I think we can cautiously think about travel. Of course, wearing masks at the airport and still remaining extra vigilant because you don't know for sure if the vaccine works in you.
Thank you so much. Our next question comes from a patient who is wondering, is frequent urination a side effect of a bone marrow failure disease?
It's not a side effect of a bone marrow failure disease in and of itself. But as I said, depending on the bone marrow failure disease you have, or side effects like iron overload, like cyclosporin levels being too high, you could get kidney damage. Moreover, if you are in the hospital getting, for example, IV fluids for ATG or other chemotherapeutics that you're getting, that could increase your the urinary frequency. So it's not like a direct effect, but there's certainly a lot of reasons why it could happen as an indirect effect.
Thank you. What level of neutrophils are considered dangerous or may require, I think, prophylactic intervention, I think is the intent there with that question?
Yeah, so the absolute number that no one will argue about is 500 or 0.5, depending on how your laboratory calculates them. So that anything less than that, you are severely neutropenic. In practice, we'd like to see neutrophil counts over 1,000 to feel good that there are enough of those infantry soldiers around. So you are still, at the very least, moderately neutropenic between 500 and 1,000 or 0.5 to 1.
Thank you. Many of our patients are wondering about engaging in physical exercise. Do you consider, is there a minimum level of hemoglobin or another count that would allow someone to do a cardio workout or other sort of a strenuous exercise?
Yeah, so there are, to me, two things that you have to consider. One is you have to, practice common sense. So, if you are walking or engaging in a light jog and you're getting chest pain and you just don't feel right, then obviously you need to stop. Physical exercise is critical, it's important. And so, it's not something that we're just gonna automatically say do not do, but it is something that you have to, pay attention to your symptoms, listen to your body, and proceed with caution. In terms of numbers, generally speaking, we want to keep your hemoglobin over 7. But anytime you start getting those anemia related symptoms, maybe time to get a transfusion. And so if you're at 8, 9, even 10, you should be able to do exercise unless there's something else going on. In terms of strenuous activity, the other thing to remember is if your platelets are really low, say they're less than 50 and you decided to take aspirin or something like that, or they're less than 10 or 15, got to be very careful because anything that would have been just a minor bump could be very serious. You could fall, land on your leg, or God forbid your head, and have a bleeding event occur. And so, I wouldn't say that there's a number, but there's certainly an increased risk of bleeding if your platelet count is at or near 10.
Thank you. This patient is a 20-year aplastic anemia patient who went through ATG. Now that they're in their 60s, they're not saying how many years into 60s, but they are struggling to discern between what's normal aging and what could be a sign of a relapse. Could you maybe give them some pointers, please?
Sure. I think one of the challenges with bone marrow failure diseases is that a lot of the symptoms that you can get are vague and can happen with so many other things, like fatigue, for example, where you can have sleep apnea or you can have low thyroid levels, et cetera, et cetera. So it's hard to know when your symptoms are a sign of, bone marrow failure disease or aplastic anemia, but they are something to think about. And when you have those symptoms, and in fact, I think you should regularly have checkups with your hematologist oncologist, then they would be able to do the blood work, the complete blood count, the CBC, to say, oh, okay, your hemoglobin went from, 10 to 8, there's something going on, let's do a bone marrow. Or they may say, no, everything is exactly stable. So go back to your primary care doctor and talk about things like, potential sleep apnea, checking your thyroid levels, hormonal levels, et cetera, that could all contribute to things like fatigue. So I think you should look at your symptoms as like a red flag, and then have your doctor do the appropriate laboratory test to see if it truly is aplastic anemia related.
Thank you so much. Wow, the questions are coming fast and furious now. We have a question from a patient who wants to know, how long after transplant would you be concerned about GVHD?
It's a great question. So there are two forms of GVHD. So acute GVHD, in somewhat arbitrary way, is cut off at 100 days. So before 100 days, if you have GVHD, it's called acute. Anything after that is called chronic. Now, we know that there's something called immune tolerance. In other words, even though if initially your body or your new immune system sees your body as foreign, over time, in some people, that will your new immune system will become tolerant, and the need for immunosuppressive therapies will decrease. And so I think you're probably in the clear, if after a year or two's time you're completely off immunosuppressives like the tacrolimus or the cyclosporins or whatever, and you don't have any signs of severe graft versus host disease. We think everyone's going to have something, but that may just be a little bit of a rash, a little dry eye. We just want to make sure it's not something extremely serious or life-threatening. And if a year or two goes by and your doctor, your bone marrow transplant doctor, has sort of peeled away those immunosuppressive therapies, I think that's a great sign.
Thank you. Is serum sickness more common if neutrophils are very low? Are there risk factors for serum sickness during ATG? And then I have a follow-on question. This patient wants to know, what are the side effects after 5 days of ATG once treatment is completed? That's a lot.
Yeah, no. So the first answer, no. In fact, having a low neutrophil count is almost always the case, because you have to have severe aplastic anemia to be a candidate for ATG cyclosporin. And the vast majority of aplastic anemia patients will have neutropenia in that context. And so almost everybody has neutropenia. So it's not in and of itself a risk factor. What are some risk factors? Well, the easy answer is previous history of serum sickness. Outside of that, I'm not aware of any clear risk factors for serum sickness. And what are the side effects after day 5? Well, that's the good news, is there really aren't many. The really big thing to worry about is just the fact that your T cells just took a big hit on purpose. And so their biggest side effect is that you're prone to infections. Now, there are side effects for cyclosporin and prednisone, which you would continue taking. But if you're just asking ATG, there's just not many after that period.
Thank you. This patient wants to know, if they are double vaccinated and an aplastic patient, what is considered a significant COVID antibody spike? Are there any clinical trials going on that you know of to monitor the efficacy of COVID vaccines in aplastic anemia patients, and also the need for a booster?
There are absolutely clinical trials going on. At Moffitt, we have one. It's not specific to aplastic anemia, but certainly includes them. We're looking at all hematologic malignancies. We just don't know the answer to that. And it's certainly not the case that there's an antibody spike number that is helpful, especially if it's not present in the assay that you have, because if you have an antibody spike, you can feel comfortable that you got a good response. But if you don't, you could still have cellular immunity, or it just may be that the antibody assay used, the commercial antibody assay used, just didn't pick up the antibodies you had. And so it's a little unclear as to how to use an antibody test to determine efficacy of vaccine. I don't think we recommend that. I just think you should be you should recognize that it may not work as well in you, but it may. And that's why all experts and all doctors say to everybody, who can and is able-bodied get vaccinated, and it's to protect you because even though you do the right thing, it may be that you still have some degree of vulnerability. And so that's the biggest take-home point is because of that, that's why everyone else should really get vaccinated to protect people like you.
Thank you. The connection cut out while you were discussing growth factors for white blood cells. So the patient is inquiring as to why do you believe that this approach is only advocated for in certain circumstances?
Well, I mean, the general answer would be, I mean, it depends on what the circumstance is, and that's sort of what I was trying to get at. But the general answer is, as oncologists, as hematologists, we have to use what's called evidence-based practice. In other words, there has to be a study because especially with a lot of the chemotherapies that we give, right? They're not benign, there's side effects. And so we have to be sure that what we're doing based on data, based on studies, has been shown to help. And in the instance of growth factor, it's not something that's shown to help given routinely just to boost a number. It has shown to help to some degree. If you have an active infection, you're in the ICU, for example, and we need to do something, growth factors can certainly help in that context. But just as sort of a regular outpatient management, the data's just not there.
Thank you. Our next question comes from a patient who recently had a bone marrow biopsy, and the pathology report indicated a large increase in ring sideroblasts. In this case, the patient is wondering, is there a way to reduce the number of ring sideroblasts, and is this increase resulting in the fatigue and shortness of breath that the patient is experiencing?
It's a good question. So little background. So what are ring sideroblasts? Ring sideroblasts are, all they mean is if you look in that bone marrow, like I showed you, with a special stain, and you look at the immature red blood cells, they have blue dots around them, inside of them and around them. And those blue dots are iron deposition. And that's what pathologists call ring sideroblasts. If you have MDS, it turns out that just having ring sideroblasts is enough to cause someone MDS, number one. And number two, it's highly associated with a specific genetic mutation in a gene called SF3B1. And if you have that genetic mutation, and only that genetic mutation, it's thought to be associated with a less aggressive course. And so it could actually be a good sign in some ways. Now, the increase in ring sideroblasts, so to say that you have ring sideroblasts, usually they've got to be in more than 15% of cells. If you had them say in 20% and then they went to 80%, what does that mean? We don't know. And I'm not aware of any data that suggests that that's any good or any bad. It just means that you have the ring sideroblasts.
Okay, thank you so much. This patient said that they had COVID early in the pandemic and the recovery has been slow. They are now considered to be a long haul COVID patient. This patient has PNH and they're wondering, they've gotten vaccinated, but is there anything else that any side effects that they should be looking for in their PNH space, specific to the COVID long haulers, or that's just like normal PNH side effects?
I'm not aware of any PNH related COVID effects long term. Of course, short term, there's been some recent articles and press about that, but long term, I'm not aware of any. But what I do think is important, I think long COVID is going to be one of the more important areas in medicine moving forward. But it's not a one size fits all. So some people have long COVID because they had a horrific COVID course and they had scarring in their lungs and they're not breathing as well, and it takes a very long time for that scarring to heal. And that's maybe could be this long COVID group, although it just probably is recovery, normal recovery. And then there is this other group where they have a constellation of symptoms that have been often associated with a disease called POTS. I think discerning what type of quote unquote long COVID you have is really important, because there are different doctors that look at that. So for example, if it's because of scarring in your lungs, well, then you should be monitored by a pulmonologist, see if there's anything they can do. But if it's POTS, there are specialists for that. Often they're cardiologists or physiatrists that could assist in the management of those symptoms. And so I think it's important to sort of tease out the type of long COVID moving forward.
Thank you so much. You're going to get a lot of COVID questions, doctor. Thank you for being so gracious to answer these. Our next question comes from a fully vaccinated patient with stable disease. They're wondering, do you feel that it's safe for them to go into a restaurant and eat with their mask off?
And what type of disease does the patient have?
MDS.
Oh, MDS. Okay. You know, in MDS, there are, I think more so than aplastic anemia, at least that I'm aware of, a fair amount of studies that say that, yes, you do get an immune response in most people. And so I think, you know, again, what I tell everyone, what I tell my family, what I tell my patients is that we are living in a non-zero risk world. So can you go into a restaurant and get COVID after being vaccinated with MDS? Absolutely. Could it be severe COVID where you're in the hospital and your life is threatened? I'm not so sure. Certainly it's the case if you're healthy that, vaccinated people don't die or don't go to the hospital with COVID, really. But, I can't really give you a number. I can only say that, for the, indefinite future, we're going to be in this non-zero risk world. All I could say is that if you're vaccinated and your family's vaccinated, you've done everything you can. And then it really is up to you, because, at some point there is a risk and benefit to everything.
Thank you so much. Our next question comes from a patient who has MDS with the deletion 5q, and they've been on Revlimid for 2.5 years. Their hemoglobin has been going down over the last few months, and they're worried that the efficacy of the drug is waning. What's the next option? And this patient self-identifies as female, and they are 66.
Yeah, it's a tough question to answer without, knowing the details of your case. I would say, especially at this point, if you're not plugged in with an academic institution that's comfortable with seeing people with MDS, a lot of them like Moffitt Cancer Center, then you definitely should, so that an expert can look at everything and make that decision. But what I will say is that there's certainly still options remaining. For example, luspatercept, which was just FDA approved, could be an option, but it really just depends on all the factors. And so what I would say is that there's still options, and I would encourage you to plug in with an expert.
Thank you for that response. Our next question comes from a patient who says, the fatigue can be crushing sometimes. They have MDS and it's well managed, but they just continue to be terribly exhausted, and they don't want to bother their hematologist, oncologist with something that doesn't seem very serious. What would you recommend they do in this situation?
Well, I'll just have a couple of points. First of all, it is important, and you wouldn't be bothering your hematologist or oncologist by mentioning. In fact, they should know. There are people that study quality of life in MDS and actually have developed patient surveys. Fatigue is a huge component, and in some cases, even in people who have a normal hemoglobin. So there's something else in some people that's causing this fatigue that we don't know about. Can we do something about that? Well, if the MDS is already optimally managed, whatever that means, then probably not on the MDS side. But what I also tell my patients is that common things are still common. Sometimes internists and primary care doctors may attribute a lot of what's going on to MDS, and they're often right, but sometimes not. Sometimes common things are common. So as I said earlier, sleep apnea, thyroid levels, all of those things should be optimized. And I can't tell you how many patients I've had who have well-managed MDS still are very fatigued, and I finally convinced them to go see a sleep doctor, and lo and behold, they have terrible sleep apnea, and it gets better when they have a CPAP mask. So I think explore other options. if your MDS is managed appropriately.
Thank you so much. Our next question comes from a patient who wants to know, as they are an aplastic anemia patient who went through ATG, and now as they are approaching maturity, and in this case, I believe they mean being an elder, they are experiencing more side effects related to intimate relations with their spouse. And this patient is struggling with blood flow and was wondering, is this the kind of thing you should take to your hematologist oncologist, or should they be seeing some other specialist that you would suggest? They're a little embarrassed to say this out loud.
Yeah, I mean, I think I'm not sure that the hematologist oncologist will be able. I think they should know, but I don't know that they'll have a tool or a drug or something to give you that is going to help or fix it. And so I think, just like your MDS, just like your aplastic anemia, you wanted to see an expert. I think you should do the same for any type of, sexual dysfunction or anything associated with that, whether that be a urologist, a specialist in sexual medicine. All of those things would be more than appropriate.
Thank you so much. This patient wants to know if there's anything that they can do to reduce the number of cancerous stem cells in their bone marrow to prevent them from crowding out the healthy bone marrow.
Well, that's the goal of every therapy that we employ in MDS, aplastic anemia, AML. That's one goal. Oftentimes, and this is something that's emerging now in research, we understand that sometimes the cancerous blood cells can actually make some blood. They don't make it very well, but they can make some blood, and it could work. And so there are some therapies, a few of them that are approved, that don't really kill the cancer stem cells, but actually make them better at making the mature blood that you need. And so, whether your red blood cell has a genetic mutation and it comes from a cancer cell or not, if it's still supplying oxygen to your tissue, you really don't care. And so that's another approach that people are using to treat these blood cancers.
Thank you. Our next question comes from a patient who went through ATG twice. It failed the first time, and 2 years later, they had to go through treatment again. This patient is now 10 years post their second ATG, and they are trying to discern between what is a recurrence of their of the aplastic anemia and what might just be considered, what's a side effect of the ATG, what's a side effect of the aplastic anemia, and is it recurrence, or do they just have the flu? Do you have any guidance for this patient?
Yeah, I mean, I'd say a couple of things. So one, similar to earlier on, the symptoms are a red flag. And so if you don't feel right, go see your doctor, get a blood test. And if the blood counts are low, then a bone marrow probably would be recommended. If they're low, especially after a couple of readings, bone marrow biopsy would be recommended to see if things have worsened. The fact that it's been 10 years is great news, and it would be unlikely 10 years out. But the good news is, even if it did come back, that far out, probably most experts would recommend yet a third trial of ATG and cyclosporin, and likely you'll do the same thing that the first two did. And so I think all of those are possibilities. And then lastly, the other thing I would say is that a lot of the issues that are being raised are issues that are important to people who study cancer survivorship. And so, there is a lot of, understandable anxiety and worry associated with, okay, is this sneeze, or is this, headache, the disease coming back? And, that can lead to problems long-term. And so there are, especially in academic centers, cancer survivorship clinics. And so the next time you see your hematologist oncologist, maybe that's something to consider. And maybe they can give you some strategies to, number one, pay attention to your symptoms, don't discount them. But on the other hand, strategies to, not feel like, this disease is going to be coming back and this impending doom, especially 10 years out. And so, those would be my recommendations.
Thank you so much. We just have time for one more question. So I've got several still in the queue, and I apologize to those we couldn't get to, but I did want to make sure to ask this. During your comments, you noted that there are a number of quality of life surveys that may be on offer and available to patients who are long-term survivors. How would they research that those studies? What guidance could you give folks who are looking for a study to get involved in their local community? Where would you suggest they go?
Well, it depends on the disease you have, but I think organizations like AMDS could point you in the right direction. For example, if you have MDS, probably the most well-validated and what mostly used is called the QALMS score, QUALMS. But a lot of these are disease specific. And so, without having the details, I think you should either speak to your hematologist oncologist, especially at an academic center, or talk to the AMDS, and maybe they can point you to the right survey.
Thank you so much, Dr. Padron. I would also say for anyone who does have MDS and is interested in participating in in the impact of MDS on the mental and emotional health of being an MDS patient or caregiver, we would encourage you to take our screening questions for the MDS mental health study, which can be found at the top of the page under the link that says more. And if you click on that, your drop down will take you directly there and you can learn more about it. So you can also find out more by stopping by our booth at the virtual lounge over in the expo hall, where our staff is waiting to answer questions for you about this study, as well as other programs and services offered by the foundation. I would be remiss if I didn't also say, sorry, too many announcements here, but I would be remiss if I didn't remind all of our patients that we do offer support groups. Right now they're virtual, and you can join us this afternoon at the end of the day or at any of our virtual support groups to discuss these issues more fully with other patients and caregivers. I want to thank Dr. Padron for sharing his time and expertise with us and our patients. If you'd like to watch this session again at a later time, it will be available on the conference platform in the next hour. Just click on the session and it'll click replay, or it'll say on demand, and you can watch it there. If we didn't get to your question today, though, you're welcome to send it to us at any time. You can send an email to help, HELP, @aamds.org. You can call our helpline at 800-747-2820, extension 2, or you can go over to our Facebook page and send us a message. Be sure to visit the exhibit hall. Our next educational session will start in about 15 minutes. So you've got 15 minutes to visit the hall. And on behalf of the foundation, I want to thank everyone for joining us and making us your resource of choice for information on bone marrow failure diseases. The Medical Advisory Board, our board of trustees, and our team are